today of a 35-year-old Hispanic male with past medical history of hypertension, gout, obstructive sleep apnea that is not treated, and morbid obesity. Presents to the ER with a chief complaint of lower back pain with associated fever and generalized weakness. Patient states he is unable to ambulate. Upon evaluation in the ER, EKG noted sinus tach, blood pressure 161/110, respiratory rate 22, room air O2 sat 89%, febrile with a temp of 102.4, CT of the lumbar spine essentially negative, chest x-ray noted with cardiomegaly, flu swab negative, troponin I 0.161, initial was 0.157, lactic acid level 2.3, procalcitonin less than 0.01. Upon my evaluation, patient is noted with acute respiratory distress, significant shortness of breath, states this has been going on for about 6 months, denies chest pain, denies palpitations, denies nausea, vomiting, denies GI or GU bleeding. Patient states significant low back pain and left toe pain from gout. States he doesn't take any medication for gout because it makes his chest feel funny. ABG is noted with a pH of 7.4, CO2 46, PaO2 56. Patient on O2 at 2 liters will titrate. Initial antibiotic therapy initiated, IV saline started, pending CTA for further eval to rule out PE. Intensivist notified and patient transferred to CCU. Noted uric acid level of 14.1, BNP 218. Past medical surgical history significant for gout, hypertension, noted noncompliance with medication, hypertensive urgency, obesity, obstructive sleep apnea. Only surgical history is history of an ankle surgery. He has no known drug allergies. He does have a seafood allergy. Past family history, significant family medical history of diabetes. Social history, positive for smoking, positive for ETOH, and positive for methamphetamine use, all of which he initially denied. Testing showed otherwise. Review of systems, no weight loss, fever, chills, weakness, or fatigue. No denies visual loss, no blurred vision, no double vision, no hearing loss, skin, no rashes, no reports of pruritus. Cardiovascular, denies chest pain, pressure, or discomfort. Respiratory reports shortness of breath, dyspnea on exertion, intermittent cough, non-productive. Gastrointestinal, no anorexia, nausea, vomiting, or diarrhea, no abdominal pain or bleeding. Genitourinary, denies burning on urination. Neurological, denies headache, dizziness, syncope, paralysis, ataxia, denies numbness or tingling, denies change in bowel or bladder control. Musculoskeletal, no muscle back pain. Check that. Reverse that. Reports back pain. Positive for left toe joint pain and stiffness as well. Hematologic, lymphatic, no anemia, bleeding, or bruising, no enlarged nodes, no history of splenectomy. Psych, no history of anxiety or depression. Endocrinology, no reports of sweating, cold, or heat intolerance, no polyuria or polydipsia. All other systems reviewed and negative, except as noted above. Physical exam. He is sitting up on the stretcher, not acute respiratory distress, does become breathless when speaking. No JVD, no thyromegaly, normocephalic, iatraumatic, S1, S2, no gallops, murmurs, or rubs. Lungs are diminished bilaterally, no wheezing noted. Abdomen, morbidly obese abdomen, bowel sounds, soft, non-tender, non-distended. No CVA tenderness. Trace edema in bilateral ankle area, no cyanosis, no clubbing. No focal neurological deficits, alert and oriented ×4. Skin is dry and intact. He is cooperative and pleasant with it upon examination. We did a blood gas, pH 7.43, PCO2 46.8, PO2 56.9, bicarb 30.9, measured O2 sat 90.4. As I said, significant uric acid elevation at 14.1, lactic acid level 2.2, BNP 218. Negative urine for infection, positive for methamphetamine. Initial ETOH level was 218. Troponin 1.57, check that, 0.157. Impression, we did do a chest x-ray, shows mild cardiomegaly, no active infiltrates. We did a CT spine, normal appearing lumbar spine, moderately severe osteoarthritis about the sacroiliac joints bilaterally. Assessment and plan, acute respiratory failure with hypoxemia, PaO2 56. Respiratory therapy for O2 therapy and pulse ox, duonebs, empiric antibiotic therapy, and recommend pulmonary critical care eval. Sepsis, evidenced by lactic acid, fever, tachycardia. Blood cultures, urine culture, monitor lactic level, empiric antibiotic therapy, IV fluids. Fluid and electrolyte imbalance, hypokalemia, monitor labs, replace electrolytes. Hypertension uncontrolled, monitor and control BP, cardine, drip, resume home medications. Gout flare-up, colchicine, 1.2 milligram once. Obstructive sleep apnea, RT to evaluate for CPAP, BiPAP, PRN. Morbid obesity, encourage weight loss and a carb-controlled diet. Stress ulcer and DVT prophylaxis, famotidine and Lovenox. Fall precautions, aspiration precautions. Pain management and control, follow-up with labs in the morning, discussed with patient and family, all questions answered. Thank you.